Known as the Godfather of the patient-centered medical home, Dr. Paul Grundy is on the leading edge of AI and transformation in healthcare and life sciences. He's one of only 85 individuals selected to IBM's Senior Leadership Forum. His work and thoughts are frequently reported in the New York Times, BusinessWeek, Forbes, The Economist, the New England Journal of Medicine, as well as TED Talks. His foresight and groundbreaking work into new care models made him a strategy and execution leader for IBM's global healthcare operations, and he's won many prestigious awards in the world of healthcare and business. We're honored to have him here with us right now on Red Hot Healthcare. Let's go.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and welcome to the show. I'm your host, Steve Ambrose, and you can subscribe to Red Hot Healthcare on iTunes, Stitcher, and other podcast directories. And we love to hear from you. Just send your comments or questions to steve@redhothealthcare.com or hit me up on my Twitter handle, PolymathSteve. Today's show is being sponsored by Medisend, any size medical office, facility, or hospital. Let Medisend analyze your current medical waste services and fees. You can remain with your current waste vendor, and Medisend will lower their ongoing fees to you. Medisend gets paid only if you save. Or switch your medical waste services to Medisend. They often save new clients up to 30% or more off current vendors, and fees remain level from year to year. Just go to redhothealthcare.com, fill out a few fields. Guys, I can't do any better than this. Medisend is good people with great intentions. Save with Medisend today. And now, we're ready for the show. Dr. Paul Grundy is Chief Medical Officer and Global Director of Healthcare Transformation for IBM's healthcare and life science industry. He both develops and executes strategies that support their transformation initiatives in the healthcare industry. Dr. Grundy is also a healthcare ambassador for the nation of Denmark and the founding president of the Patient-Centered Primary Care Collaborative. He's won the NCQA Quality Award, shared by the likes of Senator Ted Kennedy and Dr. Atul Gawande. Dr. Grundy is a member of the National Academy of Medicine. He's won the prestigious Barbara Starfield Award for his national and international efforts and success in primary care. It is our privilege and pleasure to have him on the show today. Dr. Grundy, thank you for taking time out of your busy schedule to be with us here on Red Hot Healthcare.
Only a pleasure, Steve, and it's an exciting day because a report just came out from the American Academy of Family Physicians that a full 45% of active members of the American Academy of Family Physicians are now in a medical home.
Oh, that's great news, and we're going to get heavy into that. And Paul, you have a really interesting history, and one that led to your present duties and position at IBM. I want you to take our listeners down this road. It starts at the U.S. State Department years ago, and it takes you through several different stops to where you are today. So please, when you want to jump in and just share that, we'd be most appreciative.
Yeah, I was so privileged to be a member of the diplomatic service of the U.S. Department of State, serving in places like Russia, South Africa during the AIDS epidemic. It taught me a number of skills, the diplomatic skill that you really would need to have to deal with delivery transformation. I was fortunate to have Shirley Temple Black as my basic instructor when we went through. She was the head of protocol, basic instructor when we went through our orientation courses. And, to sit with people like that and really learn what it means to be diplomatic, the skills of diplomacy, I found them very useful.
Shirley Temple, the Shirley Temple, was one of your teachers.
Exactly. She was the head of protocol for the State Department. She served twice as an ambassador. She never went on in an acting career as an adult. She rather spent her entire life in diplomacy, and she was an amazing, amazing teacher. And I was really, really lucky to have her as somebody to fall back on when there was questions of protocol.
All right, so Paul, you're at the State Department. How do you get from there to the world of healthcare, the world of medicine? How does that happen?
Well, I was in the world of medicine in the State Department. I did a tremendous amount of work in Southern Africa, helping to coordinate our government's response to HIV/AIDS. And then I was moved to Russia, where I interfaced the end of the Soviet Union, all of the new republics, in the same sense that a military attaché would interface on the military side. I interfaced on the healthcare side, and it was a very exciting time with all the transformation that was going on. I have the privilege of being with our ambassador Strauss, pushing him up on the flatbed truck the day that the Soviet Union ended, and being very engaged with the ministers of health as that transformation occurred.
It's an incredible moment. I want to focus on one of the biggest passions in your life, and that is the introduction and growth of the patient-centered medical home, also known as PCMH. A number of our audience members are going to be healthcare consumers. Just briefly, if you could, can you explain what a PCMH is and how that model of care came to be?
So the patient-centered medical home is a combination of different concepts that primary care was talking about in the early 2000s. It was articulated pretty well in the American Academy of Family Physicians' Future of Family Medicine, but the concept of the medical home goes back to a paper written in Pediatrics way back in 1968 by a guy named Calvin Sia. And the concept of the medical home was, if there's going to be data about a patient, all that data should be in one place, particularly when you're dealing with people who have complex medical diseases. And specifically, he was dealing with children with special needs. The very first sort of specialty that got on top of that was not primary care. It was the transplant surgeons. They had this amazing population of very sick patients, and they quickly realized that all of their patients needed to meet. Everybody had to have the same sheet of music if they were going to make a difference in somebody's life. If you have 5 specialists doing 5 different things and you don't have a conductor, the patients would die. And so what led me to this concept was one of my bosses almost died of a drug-drug interaction. And that happens every 3 minutes in this country. It's unethical. It's immoral. It's unacceptable to have 5 specialists in no adult supervision when you're doing something as dangerous as providing medication, that the interaction of those could kill you.
I listened to one of your talks online that you had done. It might have been earlier this year, and you said it is the equivalent of a 747 jet full of people dying unnecessarily every single day in this country.
That's exactly right. I mean, I think the list data shows that it is the third leading cause of death is medical error. It's actually 2 747 jets that crash every day, and much of that is unnecessary, unwarranted. And when somebody is lucky enough to have a comprehensive, somebody who manages their care, it costs 1/3 less money, and the mortality is 19% lower.
You know, and that's one of the questions I wanted to get into, was the major benefits of the patient-centered medical home versus the traditional model. I mean, just to be clear, we're talking about a PCMH. We're not talking about people actually being in their home, being treated with doctors coming to them. We're talking about it more being a centralized data resource where the primary care doctor, I guess essentially, is the driver and the coordinator of the patient's care, but all the doctors are keeping their data all in a centralized place that they all can tap into, sort of in care coordination. Do I have that right?
That's exactly right. So it's really combining this concept of the data in one place with a concept that Ed Wagner developed around chronic disease management, and a concept that Bodenheimer and Kevin Grembach developed around advanced primary care, team-based advanced primary care. It's taking those elements and really guaranteeing access, convenience, coordination of care, where the medical home or the place where you get your primary care from is the quarterback, is going to be accountable for being the person who coordinates your care, integrates your care, and does not allow things to slip through the cracks. And this is the model that has now become really the standard of care underpinning accountable care in our country.
Today, I know that providers have a bit of a decision to make. Care is going to have to get coordinated. You got multiple players, people are going to multiple doctors, and I know there's a decision to be made between the patient-centered medical home and the ACO model for coordinating care. And I'd like you to talk to the audience a bit about that, maybe some of the differences between the two, and where you see that perhaps the best decision might be for one type of provider entity, maybe versus another.
So the accountable care model is really about accountability. It's about stepping up to manage a population in an effective way. The conclusion that all of us have reached around this, and we've had many conversations and many papers written, is that the foundation of accountable care is the place in a delivery system where every patient has a plan. Because without a plan, how can you be accountable? I mean, you've got to have a place in a delivery system to manage a population accountably if you're going to manage a population. I mean, is that going to be done, by a specialist that focuses on one body part? I don't think so. I mean, it just makes sense that primary care, the place in the delivery system, which is accountable for the whole patient, would be the part of the sick care system that would deliver that accountability. And we've seen just tremendous examples of this happening. So in Tulsa, Oklahoma, which is one of the comprehensive primary care pilot systems, we began having the specialist paid to answer the email from the primary care doc. So all of a sudden, that pediatric rheumatologist didn't have 40% of her practice sitting in the waiting room waiting to be weeded out because they were in the wrong place. And then the specialist didn't get paid until they sent the email to the primary care doc answering what was going on. So you begin to have this coordination of care, which we refer to as a medical neighborhood, right?
Right.
Integration of specialty care and primary care. I mean, there's only one way to herd a cat, and that's to move their food.
Yes.
And their food was moved, right? And it was just phenomenal to see the response of that. When 4% shift occurs in their referral pattern, they begin to ask why.
How do you think that the advent of the PCMH is going to change what's been going on as a trend with more medical students wanting to go in as specialists because, the compensation to family doctors or primary care doctors seems to have been going down? How do you see that shifting? Do you see the salaries and the job security and maybe the demand growing on the PCP side?
With the patient-centered medical home movement, we are now in year 6 of an increase in applications for primary care, family medicine residency training program. We have seen family medicine being the most demanded, general internal medicine as well, specialty people are asking for. There's real optimism when I go around and I meet the medical students about a future in primary care. But I think many students go into medical school thinking, that's really what I want to do. I want to go back to my hometown. I want to be that doc that cares for my population. Until they begin to see that the guys who specialize in reading X-rays make more money. But for the first time, actually 3 years ago, the folks who graduated from cardiothoracic surgery didn't have jobs, right? I mean, there is when you begin to manage a population, you begin to actually do that effectively, you have a significant decrease in the need for cardiac surgery.
Yeah.
I mean, fundamentally, I remember going to this hospital on the East Coast, and it was a big sign that said, we do the best heart surgery in the state. I went into that CEO and I said, that's not the sign I want to see. Do you get it? I want to see a sign that says we manage a population so well that there's 1/3 less need to do heart surgery. And there's places where that's actually happening today.
I get email from listeners that want to know what I do. Hey, I'm a consultant working in 2 areas. First, multi-level consumer engagement. I provide tactics and strategies to direct engagers, such as hospitals, payers, life science, and medical technology companies, and to indirect engagers, companies that sell products, software, and services to the direct engagers. If you haven't created tactics, strategy, and partnering around engagement, don't be surprised when consumers continue to close you off. Second, I'm a heavily connected networker who strives to connect pieces that drive innovation, collaboration, and mutual benefit. Every relationship I carry across multiple healthcare industries is open for contact, conversation, and business. Everything's changing in today's healthcare, and in many ways it's become an unsettling and yet opportunistic Wild West. Reach out to me if your company would like new thought, tactics, and strategy to increase growth and profitability. And now, we're ready for the show. So I want to switch over to IBM, and in particular, let's start talking about artificial intelligence. Let's talk a little bit about Watson. I know that you are very instrumental in those efforts moving forward on a global basis as well as here in the U.S. I've listened to you speak, Paul, on IBM's betting the ranch, as you call it, on this technology. Technology that focuses quite heavily on, we can call it probabilistic versus programmatic technology, and the way that technology and computers are used in healthcare. So let's sort of start a little bit from the beginning here, because you were around at the beginning time. What led IBM to take this position and sort of make this bet on AI and Watson and what they're doing today?
It's really interesting. When I sit around with my bosses at IBM, they don't just ask the question, where can I make money? They ask the question, where can I make money in doing something nobody else can do? And part of the dilemma that we've had in healthcare is that healthcare has not responded to the information age in the same way that many other industries have. We can launch a rocket to the moon, and IBM was involved in that, and return them safely following the laws of physics. But managing 100 diabetics is a gazillion times more complicated, dealing with the human behavior part of it. So we really felt that a whole new era of computing would deal with that. And that new era is cognitive, right? It really getting machines to work with human beings, to learn from human beings, and to support a human being so that they're no longer 100, 1,000 years behind in their reading. So the information they need is available to them at the point of care. So that data can be aggregated, structured and unstructured data at the point of care, so that we're less likely to have a mistake, right? It's really about that. I mean, I had the privilege of spending a few days with Dr. Christ, and we were dealing with a patient that was referred down with lung cancer. And Watson basically said, this is the treatment that I would most recommend. And when you look at where they found that information, where Watson found that information, a paper that had been published the week before in an Israeli journal of 37 patients with that particular genomic subtype of that disease, was available at the point of care. And so I said to Dr. Christ, how long would it have taken you to find that? He said, I don't know, but probably a long time. I mean, so it's that sort of thought process on one side. On the other side, it's being able to read 380 pages, which this patient came down from Albany with, which were digitized but unstructured, and sort that out and deliver that at the point of care. So it's really an augmentation tool. It's combining and supporting the human brain. Frankly speaking, right now, our model of care is a master builder where the doctor's brain is a storage device. That's not a very good storage device. We forget. We go to sleep.
Right.
Our brains are programmed to forget things. So, and even though we can read, we can probably read a few hundred papers a year. I mean, Watson can read millions of pages a second. It's just a whole order of difference. So it's really thinking about how do we take an ability to have a machine help a human being, support a human being to make less mistakes, to be right more often.
Right. And, the differentiation here, just for the audience, I would put Watson, probably as a type of artificial intelligence we might call intelligent augmentation. That is, being able to cognitively help humans, as you say, at the point of care by taking in massive amount of information, being able to analyze that information, and being able to deliver specific best evidence and suggested actions from it, where, as you say, people are extremely limited, not just in generally in what they can store in their brain, but they have feelings coming in. They have other thoughts coming in from left and right that they can't properly sort. Sometimes they may have their own personal issues. They may have business issues. They may have, family issues. And when you look at it, you're right. It really just is a poor substitute for the power of a technology that doesn't have those limitations and that not only can take in massive data, but as you say so well, can find that one little needle in the haystack that perfectly lines up. And Dr. Christ is at Sloan Kettering, right? The cancer hospital?
That's correct.
Okay, yeah.
Yes.
I mean, we're talking about real human lives here. We're talking about the differences between identifying properly and not properly, living and dying, especially in the case of cancers, when it really starts to come down to just how limited the human mind is and what sort of results come from that limitation.
And, when you stop and think about it, we used to build cathedrals out of somebody's head. They were the master builder. We don't do that anymore. We don't build skyscrapers, with a master builder. We have a plan. Every patient should have a plan. I mean, we have a plan. We have data. And so I honestly think that when we move away from this Flexner master builder model of care to a team-based model of care, and we think about every patient in our practice proactively being managed with a plan. It could be a simple plan. It could be one that just is as simple as my cat. It gets reminded of its immunization. It could be really complex for somebody with multi-organ system disease.
Let's take the technology Watson has now. We can go so many different directions with it, but let's stick with the PCMH model. From where the PCMH model started some years back, and as good as it is, what has Watson been able to do in the PCH model with its technology?
So Watson Health is not just cognitive computing, it's also getting at the data, supporting the doc with the data. So there are really layers of this. So the first layer I would call the source of truth. How do you get the data in one place and begin to act on that data? The second layer up is how do you take that data down to a population cared for by one doctor and understand what's going on with that population. Then carry that to a place in the delivery system, down to the individual case and the plan for the individual case. And then up to the next quadrant, which is performance analytics and looking at how a particular physician or patient is performing with all these issues that they're dealing with. And then the last quadrant over is what does it cost? IBM began looking at where in the delivery system were the best results coming. And so by far, the docs who used a tool called Fitel at getting at and managing that population data, they were best in class, KLAS, right? So IBM acquired them, right? So the very best performance tool at getting at who was performing comes out of the Cleveland Clinic with Exploris. So they acquired that. And for the cost, they looked at and acquired Truven. So it's getting at that data and then taking that data and beginning to make that cognitive is the journey. And the cognitive part of that journey, we're really just beginning. There was a 60 Minutes special a couple of weeks ago on cognitive computing. And the person who leads that in IBM was asked, how far down the road are you? Are you 10% there? Are you 15% there? Are you 25% there? And he said, no, we're in single digits, right? This is just beginning. It's sort of like a conversation you might have with delivering goods, 120 years ago, where you had a bunch of delivery men talking about whether they were going to reshoe their horse Daisy or they were going to buy this newfangled thing that didn't have a horse when there were no roads and there were no maps and there were no gas stations. But the future was there, right? Those who didn't do that, who reshoot Daisy, were out of business within a decade.
Let's chat a little bit about where you see the role of patient engagement. So we've got lots of technology out there. Watson's certainly leading the way, and there's all sorts of other technology out there that we could get into on another show. At the end of the day, though, you really do need to change behavior of patients, or you need to get them to want to change their behavior, I should say. So How do you look at that at IBM, or maybe from the other initiatives you have with PCMH? Where do you see the role of patient engagement? Do you see that being something that the doctor has to do directly with the patient only? Do you see technology companies having to design patient engagement within their products and services that they give to doctors and hospitals? Maybe you could speak a little bit on that.
I certainly will. I mean, I already think of this as three legs of the stool. If practices are going to transform and deliver and manage a population and move away from an episode of care, and if they're going to pay to do that, they're going to transform payment. The third leg of the stool is how do you engage the patient? How do you design the benefits around the patient to better support that? There's a lot of behavioral economics that come to play in this because as human beings, we do not often go down a logical path. We tend to be driven by short-term rather than long-term understanding. But how do you begin to think about and what's the science around that? We know some things now. We know that people need to not lose is stronger than their need to gain.
Loss aversion, right.
So when you begin to design systems in which you notify the patient, and I've seen the tools to do that if you had taken those pills, you could have had a chance to have won that $100 lottery. But something as simple as a little tort reminder for people to take their pills and a little system in which you begin to engage the patient slightly differently, beginning to understand the loss aversion, beginning to understand human psychology, you begin to see change. How can we as social beings be supported in a community to sort of circumvent those weaknesses that we have as human beings? We do not make rational decisions, right?
Right. Often emotional ones, and often, it's finding the value in something. Like you could sit there all day and tell somebody who's 21 years old, don't smoke, don't smoke, don't smoke, don't smoke, and they'll just continue to smoke. Oh, don't smoke because chances are, you'll lose 10 years off your life. Like you said, that doesn't matter to them at 21 years old. But now when they're 48 years old and they just got a lung cancer diagnosis from their doctor, now they're going to be the first one to throw their cigarettes away. And because now they have the impetus, now they have the right driver, unfortunately, to get them to make that decision. So, to your point, it's really like looking at the individual and finding what's going to be that lever. What's going to be the lever to really get them to commit to something meaningfully so that they stay with it? Not so that you can just get them to say, yes, I'll do it. Yes, I'll do it. You've beaten me over the head with the data. I'll do it. It's more like, when they leave your office, right? How do you really get them to stay with it? So, no, I take your point very well. I know that you work in IBM in the healthcare area, Paul, but also you work in life sciences with AI and technology and transformation. So I really wanted to come at you with this question. Where does Watson come in to the life sciences industry? Where do you see Watson's role?
Well, actually, I'm pretty excited about the possibility with cognitive computing, Watson, and R&D for drug development. And I think the reason I am is because artificial intelligence supporting the human brain can recognize patterns that we could never see. And I think it can cut down on the number of false starts that occur with drug development. In sort of looking through the world's literature on a particular molecule and how that molecule might fit into a particular receptor, the potential there to make it shorter to develop a particular chemical compound is, I think, really exciting. Just the power of cognitive supporting that human brain to see patterns broader than we can do as a human being is phenomenal. We can sort of store about 7 different things in our head and put it together, but cognitive computing can do millions. It's just a profoundly more powerful support mechanism for us.
We're talking about, from what I've read here, the ability for the drug companies to sift through hundreds of thousands of different patents, just in making sure when they're developing a molecule, it's not infringing on anything that would come back to bite them. And then being able to look at, all the possible offshoots
of, maybe they start a drug in one direction and then they find there's 3 other directions it can go in when they analyze the data out there and other uses for the drugs and that sort of thing. I mean, just it's human cognitive limitation that plays a big role in ultimately what's causing the average drug, as I understand it, to take 10 years to hit the market.
If we can make that process shorter, if we can make it more efficient, and I'm very optimistic that cognitive computing can help support that. There's a huge amount of interest.
I have really enjoyed trading thoughts back and forth and learning so much from you today. I know our audience is pleased as well, and we are very much looking forward to having you again on in the future. Thanks for coming on the show, and thanks for spending time with us today.
Steve, you're red hot, and it's great to be with you as well. Thank you very much.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.